Thanks very, very much, Mel, for that nice honour. It's always nice to hear dates that go with things that I vaguely remember doing, because then somebody, if they ask me, when did you do that, I say, well, it was 20 to 40 years ago, and that's been my stock answer. So every now and again I pick up an extra refinement on that. Thank you also to Jeff and Joyce for your gift to optometry, basically, of this annual lecture. And I'm pleased and very proud to have been invited and named by your committee to do it this year. It's a pretty tough act to follow with Irvin Borish and Mitch Scheiman, and but I'm pleased to give it a shot. I've been lucky to have over what Mel described as 45 years. It's about right on the money. Thank you. I would have said 40 to 50. The many journeys, and even within the research arena, many journeys, and quite a few, and a few optometry schools to boot. I won't talk about the fun journeys that are probably more relevant to some of the people in this audience, like Carla and Don and others, the myopia journey that they took me on. And I won't talk about the one that Roanne asked me about today, the wild San Francisco journey with recreational drugs as the topic, or even the animal research journey with my goldfish in hand. I will, because I'm frightened I'll miss it, if I do miss it, let me say it now, Ewan, you'll see quickly in the early few slides something that you inspired your graduate student who became postdoc with me, Frank Zisman, to get into. So the journey I want to focus in on and try to keep within the timing. I see it's 5:25 when I started. I get what, until 6? Okay, thanks, Mel. Did you hear what he said? You're going to spoil your reputation, Mel. This is a journey that actually has a good ending. It's just, I'll try and tell it in a story-like fashion. So the chronology might have been a bit distorted here and there. If my graduate students who were involved in this were listening, they'd say, I did that before that, or you didn't do that before this, or something. But it's a story, but it's based on fact. The story basically is about diabetic retinal complications, and my lab's interest in this since 1978. And so it's a long time frame, hopefully only a 30-minute story. Let me just give, for this audience doesn't need it, but just to context, diabetes has become increasingly obvious as a huge, huge problem. I just read a week or two ago that the estimates right before a big conference that was going to play this up, that there are something like 366 million people in the world who are diabetic, and that's at about 60 million more, not in the US, in the world, 60 million more than it was about 3 years ago. And we know that the eye complications leading to the eye complications are a leading cause of blindness in the working age population. It's not the leading cause of blindness in the US for any disease, but for that population. The eye problems can be among the most nasty of the complications. So what's the optometric role in this? Well, I would just remind you that we as optometrists see the patients at what is really an earlier stage than our colleagues in ophthalmology see the patients with retinal complications. And that will be something we'll build on. What our colleagues see, or we see and refer almost immediately, is a couple of very significant issues. One's when there's edema, particularly if it's sight-threatening or anywhere close to the fovea. Macular edema is a vision taker. And the other one is the proliferative retinopathy, where you get new vessel growth, particularly if it's particularly a problem if it's at the optic nerve head. These are nasties, and you know the treatment. It's go in there and blast away. It's laser therapy, and there are, as I'll note here, other efforts to find non-surgical interventions, medical ones, for even those advanced stages, and probably only for those advanced stages. Now, the personal interest that I've had in this research since early 80s has been based on my bias as an optometrist, that the early stuff is seen by optometrists, that any prevention of the complications is best started at the earlier stages, and one day there'll be good ways for optometrists to play a more significant role. And I think the end of my story in about 20 minutes will be, I think we have some of those ways, and they will find their way into practice in some form or other. So I think we can bring solutions to the prevention part of retinopathy. And I also think, from a selfish researcher point of view, that's the stage from the point of view of research when things are less complicated. In other words, once you get a really stewed up eye from the advanced complications of diabetic retinopathy, you've got all kinds of things going on, including even losing some acuity, but all kinds of more complex things to study as a researcher. So my philosophy has been that it's probably a little easier to identify simpler solutions if you start early, at the earlier stages. So that's the reason why our labs have gone in that direction. They're sort of following my bias and have been apparently comfortable doing it for a while. I've been fortunate that it's been funded ever since 1978 by the National Eye Institutes. So in this next, not 35, but less now, minutes, there are really 7 questions. The first 2 take half the lecture, in case you get panicked. And they're really, hopefully, a logical sequence. The first is the question of, if you're going to start early, what are the early functional changes that you see in diabetes in the eye and with vision? And it turns out you'll see the answer is there are some neural ones that are pretty early. The question is, are these changes that you identify, are they local, whether they're vision changes or retinal physiology changes? And if they're local, good, but are the local effects correlated in some way with the vascular effects that we're traditionally interested in looking at, which is what we call retinopathy? Is basically, we don't stop and think about it, but it's all vascular. When we look in and grade retinopathy, we're grading vascular complications, not any of the other ones that turn out to be taking place in that same retina. And are they associated? Do you know, if you see one being affected, is it likely to be in the area where there's also some vascular problems? And do these neural changes, and I'm tipping you off, that's what we found, do they increase the risk of getting that vasculopathy further down the line? Not just are they associated today, but does one measure relate to what will happen eventually? How early can you see these changes? And I'll mention just quickly, mostly in adults, but we've got some sad but interesting stuff on adolescents, teenagers. Can those neural changes actually predict? I mean, can you quantify the prediction of the specific site where retinopathy will appear? Is that possible from this sort of research? And then finally, mostly as because I was sort of beaten into submission on this, I would always get, so what if you can find retinopathy? There's nothing to do with it. Why don't you do something useful and maybe predict retinal edema, which really is a problem, and we will treat it. So it's based on, from my perspective, the present. You know, we can treat retinal edema or proliferative retinopathy. We more or less don't want to treat the other because we don't know what to treat it with. So why aren't you getting on with the job? And finally, we did look at that, and that's where I'll finish today, talking about the prediction of site-specific edema, that is edema in a particular part of the retina that you can say with a certain degree of confidence will occur X years ahead. So the first question, what are the subtle early retinal and vision changes that we see with diabetes? Well, you ask clinicians, they'll have some pretty good answers, especially if you ask optometrists, because they see them early. But what we do know is it's not visual acuity. So scrub that one off the list. Visual acuity only changes in diabetic complications of the eye, of the retina at least, very late in all of this, in those severe cases with edema or proliferative. In other words, the terminal stages of the retinal complications. So it's not visual acuity, but guess what? That's the endpoint for a lot of the research clinical trials that take place. It's, as they say, a no-brainer. You can't, if you're waiting for that, you'll be waiting 30 or 40 years for a given group of diabetics. And by that time, you're dealing with really advanced cases. So what's really needed is functional biomarkers of the retinal health that are early and would predict the subsequent diabetic retinopathy. Because once you've got those, you've got a marker against which you can try out your idea about what the next best preventative medicine is or preventative procedure. And what you'd like to be able to do is to do it in a way that you know which patients and which parts of their retina are going to be like this. But as I said, visual acuity and, as it turns out, visual field simply fail to do this in the very early stages. And you'll see in a moment that we took a shot on the visual fields and we got excited and then we didn't. So let's look at those early changes. Optometrists know that you can get in patients with diabetes some early and very subtle vision changes if you listen to the case history or even make some measurements. There's often, but not reliably present, a reduction in contrast, probably mostly due to lens scatter. There's a sensitivity to glare and even glare recovery on a time basis. Again, a good chunk of that might be crystalline lens scatter, though some of it could be retinal. And then there are also subtle colour vision changes, so-called blue-yellow changes, which unfortunately aren't in the books of most of the practicing optometrists' colour vision tests, which are red-green. So let's just, we decided very early on, and this is the tribute to Ewan that I wanted to make, we decided to do something that Ewan and others had done and try to actually look at each of the cone types in the retina, since colour vision was changing in a subtle way but with fairly crude clinical instruments. Why couldn't we go after each of the cone types themselves with some clever vision testing? And so we did try colour. If you look at the electromagnetic spectrum all the way from the violet end to the red, there are actually three underlying photoreceptor types, which we'll call red, green and blue. And they actually, except for the blue, capture photons across most of the spectrum. But you notice here, and I've taken a little bit of license, but you notice here that the red and green photoreceptors capture the blue light almost as well, or maybe even better, than the blue receptors. That's why the sensitivity is higher in that on the left-hand side. But you can do something about that. You can have somebody look at a bright yellow patch, and that bright yellow would come from, say, light that came through a filter that let the light through. I don't know if this pointer works, but you can see that horizontal bar over the G and R. That's the light that's coming into the eye. And when you do that, you actually depress the sensitivity of the red and green photoreceptor systems. And you do so enough, if you look at that yellow light for a couple of minutes, that if you take a patch of violet light now, it's the blue receptors, if you flash it on, it's the blue receptors that pick it up. And we tumbled onto this, or didn't tumble onto it, I mean, we were going down a path that others had shown. And in the early 80s, we indeed showed that a lot of diabetics show rather big blue cone sensitivity losses. We call them blue-yellow sensitivity losses. And so that was very exciting, and we published it, not very much, but published it, and said, this is great. However, as you know, diabetic retinal lesions are not restricted to the fovea, which is where we were testing. They're across the retina, and they're no more likely to be in the fovea than they are anywhere else. And so later, and this is where the time warp would come up, much later, we actually took some blue-yellow perimetry that we had developed to study glaucoma down in Fort Ord in California in the Monterey Bay area. And then we coupled up with Chris Johnson, who really took it and made it a real good science and made it into automated perimetry. And nowadays that's called SWAP. But it's essentially a blue cone perimetry. So it was rational for us to go after other locations other than the fovea. And we did, and guess what? Diabetics who have no retinopathy at all actually have about 20% of their visual field, central visual field, with the SWAP field defects, blue cone sensitivity loss. That is, they're abnormally low. Unfortunately, the measures in those locations are not closely associated with where the retinopathy is. There are some studies that make it look better than others, but in our hands, they were not tied closely to where the retinopathy was. And worse, they didn't turn out to be predictive of subsequent complications of retinopathy. So it was a good try, and we finally published what we found on that. It's about double that if you've got eyes that have some retinopathy. It's more like 40% of the patches are abnormal. So it's an interesting finding, but in our hands we couldn't take it very much further. But we have had, and I'm calling it a recent success, but I mean it's really more than a decade since we first cleverly arrived at this conclusion. So we discovered that there are in fact some measures, and they are basically related to electroretinogram measures. And there's a condition that many of you in this room know, a measure called multifocal electroretinograms. And I'll say a bit more about that in a moment. But through these electroretinogram signals, tiny signals, it turns out, and here's the bottom line of the story if you have to leave in the next 3 minutes, that these markers, the reduction in function seen in these electrical signals, are markers for not only allow you to predict future diabetic retinopathy in particular patches, the onset of that retinopathy, and even edema onset, the last question that we ask, but also the actual location of in the retina that this occurs with some confidence, and I'll explain what I mean by that in a moment. So here's what we actually ask people to do when we're doing this test. They look at this grid, and you say fixate straight ahead and just keep your eyes open and behave yourself. And if you have to blink, you blink, and so on. And we watch them through, and you've probably got one in your own clinic. Do you have a multifocal setup? Do you know? Anyone know? You probably do, actually, nowadays. I think Bill Swanson probably has one. Are you over in your shop? Yeah, okay. So here's what they do. I mean, these are now commercial instruments. They drive an epileptic crazy, but here's... so you look straight ahead, and while you're looking ahead, these black patches reverse to white, and the whites reverse to black, and they go through this 16,000 white flashes, which means another 16,000 black ones, so it's got over 30,000 flashes, all within about 8 minutes. So they're just sitting there looking, and mostly, apart from being bored, and to relieve that, we stop them every 20 seconds and say, that's it, go again, and start it up, and by 8 minutes we have something that looks like the following. So those are the patches, that's where they are, and that's roughly the angle out on the retina, out 20 degrees from the fovea, a bit more actually. And this is roughly how that corresponds to the fundus picture, and this is a slightly better picture. There's 103 of these little honeycomb hexagon shaped features. And so the magic of it is, that I don't fully understand and certainly can't describe, is that when this goes on, with knowing the sequence of flashes for any given location allows you to derive, even though you're only getting one response, to derive what the response was for that particular location. It's called an M sequence, and engineers are really comfortable with this, and I'm not. So you can actually do it. It was invented by Eric Sutter out in San Francisco, and he's built a whole company out of it. Person looks in, if we're going to try and gather these signals, they look in, and what they see is that pattern I just showed you. And then at the end of they wear a contact lens, so we get the signals. This is, for research at least, the best one to use because the signals are robust. But other people do it with little filaments, nylon filaments on the lower lid. And what you get is a clever printout in the commercial instrument of what I'd call a hill of function. It's like the Tracier's hill of vision, but it's a hill of ERG function. And with a peak in the middle and dropping off and dropping to nothing almost in the, as you'd hope, in the optic nerve area. That's the response that you would get at each of those 103 locations. And it looks familiar to those of you who've looked at ERGs. And what we're measuring is what's called the implicit time, or the delay from the onset of the light flash to the first positive amplitude there. What we would call maybe a B wave in a regular electroretinogram. So this implicit time turns out to be the joule, because you can also measure the amplitude from trough to peak, and lots of people do, and in some diseases that turns out to be useful, not in diabetes. So that's the summary slide, 16,000 flashes, of white, plus 16,000 flashes of black. And then you get the image on the retina, you get this little array, and you get a printout. And you can display that in a three-dimensional array, and you can display it like OCTs with all kinds of fancy ways with pseudo color and so on. But those little signals are tiny, tiny, tiny. That's why you need like 30,000 of them. They're in the nanovolt range. But they're quite clean when you finish, because all the noise has been drained out of the, with the 30,000 trials, the noise cancels. So you do get something quite worthwhile, and in a way quite surprising and tiny compared to an electroretinogram that we would have done or had our students do. Where does that come from? Pretty clear now that these responses are pretty much at the levels that we do this from cone photoreceptors. They initiate the response. It's not a rod-dominated response. And the major components that we're looking at are really in the middle inner retinal layers, sort of bipolar and amacrine cell range. So that's the end of the physiology. We spend a lot of time on the physiology, but that's 10 years I'm not going to go through. Are they local? There's a quick answer on this one. These defects are local. That was the whole reason why we took to dealing with them in 103 locations. Here's just two quick examples, and it gives me a chance to introduce how we score these. The pink and the red are greater than 2.5 standard deviations worse than the control group. And I won't mention controls again, but for all of these studies, you have to build a control group base, same age and gender and everything else. And so you get an average for it, and then you can describe how many standard deviations away from normal a diabetic is. So all those little numbers that you can't read because they're too far away are standard deviations, and there are very few of them are minus. That is, very few in this particular eye that's on your left. Minus, it means that they're nearly all worse in some way or other, sometimes only 0.7 standard deviations worse, but the pink and the red are greater than 2.5 standard deviations. So in any statistical approach, we'd say that they're out of range. Are the vascular and neural changes locally associated? The answer of that one is yes, That's good because we would have stopped us in our tracks if they'd not been. So here's Brad Fortune published this in 1999. He looked at all the patches individually and a bunch of patients, but here's an example where this X, Y, and Z are three patches of edematous retina. And if you look at on the right, you'll see that the dark shaded ones with numbers like 2, 4, 5, even 7, standard deviations worse than normal, are pretty significant, and they're pretty much where the lesions are. Next question is, does the neural change, when you see it, does it increase the risk of vascular change? In other words, is the risk different? And this one I'll do is just a quick example. It's not the full study group, it's a rather small group. But if you take patients and look 1 year later, as Ying Han did, they have patches in the backs in their retinas that are normal and patches that are abnormal. And you'll see here that if you base on normality on the implicit time, that neural measure, then there's 63 of them that are abnormal to begin with total, and there's 119 that were normal, because we're dealing with eyes that don't have a lot of retinopathy, just some. So what happens is if they were abnormal at baseline, then 1 year later, 22 of the 63, that's 35% of them, actually of those patches develop retinopathy. Whereas if they were normal, the 119, only 2 of the 119, which is like just under 2%. So that the relative risk in this little simple cartoon of the actual data is about 21 times greater if you've got an abnormal. So the risk is increased. How early in the process does the neural change, can it be seen? Is it only after we're fair way along or not? Well, I've already tipped you off that it's pretty early. And let me just show you what it is in some adults. That very first study by Brad Fortune, he looked at patches and he graded all those patches, grades from normal the normal patches, in normal eyes, sorry. In the diabetic patients I've circled, these are diabetic eyes that have no retinopathy, and he called that grade 1. And you can see even there, the normal, no retinopathy diabetic eyes as a group have significantly different implicit times. They're a little bit extended, they're a little longer. And as the retinopathy gets worse, the latency gets worse. And that's somewhat reassuring too. What about with adolescents? And we're late in the game on this one. We only started this a couple of years ago. But it turns out, sadly, that both type 1 and type 2 adolescents have delayed times, nearly always without any retinopathy at all. And the type 2s are the more complicated characters. If you've got diabetes in your family and you know teenagers with diabetes, you know they've got lots of other general health problems often, including sometimes obesity, but other problems. And it shows up, and you'll see in the yellow there that they've got more delayed times as a group. This was an initial group that we studied. More recently, and this has not been published, but Michal Laron was from the University of Houston after she did her optometry in Israel. I think makes the interesting observation, because she could. We hadn't measured it before, but hemoglobin A1C levels actually correlate, particularly if they've had the diabetes for greater than 6 years with these functional changes. So sixth question, can neural change predict the first onset of size-specific retinopathy? Now I'm talking about predict in a quantitative sense. Is there a model that says what the sensitivity and specificity is of the change, of the prediction? And this is going to be rather glossy. My graduate students would be on my case on this, but we've got a few minutes left. They are predictive. Let's just take the first group where we combined it over a number of years and just took the group that we had for 1 year and 2 years, and we looked at the model building for after 1 year, if you've got the functional baseline measurement, what kind of predictions can you make after 1 year about retinopathy onset, and what kind of predictions can you make after 2 years? Now, intuitively, you're going to say, well, your predictions will be better after 2 years. Well, they're not, and there's good reason for that. But also, we were dealing with people where the odds were stacked against us. Look, 14 started off in this study with no retinopathy, 6 with some. And most of what we're talking about actually took place with the ones that had the retinopathy. Well, of course, we had to get rid of the ones that had retinopathy at baseline. Those patches are not interesting if you're trying to predict the onset of retinopathy. And then after 1 year, 21 of the zones, which is a small number compared to the total number that's looked at, got retinopathy, and by the end of the second year there were 47. That's all very sensible. Now what we did here, and this is a bit of sleight of hand because I haven't mentioned it to you before, but for a number of reasons, I think all good, we actually didn't look at the 103 patches. Part of it's a registration issue. You know, how confident are you got exactly that place and so on. We formed them into 35 zones, and the 35 zones are the bottom left, and they correspond not roughly, pretty closely to the retinal fundus, which is sketched on there. So in the predictive modelling, we used, with the help of good statisticians, logistic regression, and then we used some GEE approaches to construct the models for the prediction. And we used what we called a multivariate model. That is, we put in something other than just the implicit time, which is what we did those models too, and they're pretty good. But you get much better if you put in some reasonable, rational, common sense things in addition to implicit time. If you put in the duration of the patient's diabetes and the blood glucose level at the time of the testing. And we do this every time, and we have a lot of other measures I'm not mentioning, like blood pressure and nowadays hemoglobin A1C levels and retinal thickness measures, and there's a longer story. You're lucky you're not hearing it. So they actually can turn out to be used, and if you look at the bottom there, somewhere I'm saying sensitivity of about 86% and specificity of 84%. Let me remind you, sensitivity means that the correct prediction of the retinopathy occurring. So 86% of the time with that model, where the retinopathy was predicted to be, it was. Specificity is the correct prediction that there will not be any retinopathy. It's the other side of the coin, which is clinicians, you know. We can all be 100%, we get a test that's 100% sensitive if we fail everybody. And that's not terribly clinically useful. So you need to know both sides. So that's the last time I'll give you the little lecturette about sensitivity and specificity. A way of presenting this data that people love who do the research, and it's a very solid way of doing it, is to present them as an ROC curve. And if you look on the left, there's this 1 year model with those 658 as not patients, they're zones of the 35 per eye, remember. And there we got improbable, spectacularly good, could not be repeated results. 95% sensitivity and 93% specificity. Well, after 2 years with these people, it dropped to 81% and 82%. Still very respectable numbers, very respectable numbers. And the clue here is, why does it get worse? Is partly because the early retinopathy comes and goes. About 50% of microaneurysms that first appear are not there next year. So you know, that's a clue. It's not the whole story, but that's a clue. So in our 2004 and 2006 studies, we're closing in on this now, we were interested in the initiation of retinopathy. You know, when did it occur? And not whether was it there a year later or 2 years later. Did it persist is a more clinically interesting question if you're looking for what to do about it. As I said, about 50% of them do come and go, if you're talking about dots and microaneurysms. I wasn't taught that when I went through optometry school, but I went through optometry school in a different century. In 2008, we, meaning led by Jason Eng, who did his PhD thesis, he's down at SECO now, published a predictive model for retinopathy that involved persistence of retinopathy, and he called it recurring. So he followed people for basically it's 1, 2, 3. It's 1, 2, 3, yeah, 3 years, and the baseline is at the first year, and then he measured them again at the end of year 1, 2, and then 3, and he said he analysed it. If you see his paper that's buried under the bottom here, so that it was first of all analysed it with just any retinopathy that occurred in any one of the 3 years. He called that transient. I think it's a fair enough description. And then he said, I'll distinguish between that and recurring, which has to occur at least twice in that 3-year sample. So he says that's our way of thinking of something as a bit more permanent, not transient. And the model surprised me. We went through a lot of, can you get the rest of your thesis committee to read this carefully and get the statistician and so on. But he came up with, for persistent, that is, I'd say, interesting retinopathy onset, he was getting 88% sensitivity, that is correctly predicting the retinopathy 88% of the time, but 98% of the time correct on saying the thing's going to be normal, the way he had defined this all. And that's his ROC curves. He did a univariate model, that is, he just said, how good would it be if we just took implicit time? We didn't do a case history or anything else. We don't know how long they had diabetes or anything else. And it was pretty good. Sensitivity of 84% and specificity 73%. For the enthusiast, the area under the curve is 0.83. But that's where we got that 88, 98 from in that model. So until this time, we had published groups that already in the group, there were only some that had no retinopathy, but we were looking at patches that had no retinopathy. But the patient had retinopathy often. It's different. Eyes with retinopathy have lots of patches that have no retinopathy. So we're looking at zones. And then we were interested, and then people are sort of saying, well, that's, first of all, it's not interesting because you can't do anything about it if they develop it. But, it's not like they're people who don't already have a problem. So they wanted it both ways, and so did we. So what happens is if you take a group and you have to study them for a long time and say, if they've got no retinopathy, if you follow them long enough, how predictive is this measure for the onset of retinopathy? That becomes interesting just as a question of like how long, but it also becomes interesting if you're a drug company that wants to develop a product that stops the onset of retinopathy. If ever anyone got interested in doing that, to my knowledge, not. So that's what we did, and I'll give you the result. It's going to come quickly. There are a lot more eyes on this because you have to follow them for a long time. And the strategy was that we tested them annually for a number of years. And it turns out, and we should have guessed it at the front end, people don't get retinopathy as soon as they get diabetes. I mean, it's like head nodding there. Like any fool knows that, they're probably typically 10 years or 15 or 20. It's a long time. Not something a drug company is going to be interested in for studying a product. So what was done in this particular case was to stop the study at a particular point. A particular point was when the person wants to finish their PhD. And then you have people, or either that, or when they develop the retinopathy. When they develop the retinopathy, then you go back and look at the books and say, well, what was the functional measure for that patch 6 months before? and use that. So it's a predictive model. At first I was very uncomfortable with this. I became quite comfortable with it because it is answering the question, not the clinical practical one, but the question of in what way does the measurement you have relate to the onset of the retinopathy. So it was a way around some of the really awkward research questions. And when you do that, you don't need all of these numbers, but we're still talking about pretty good sensitivity and specificity from people who had no retinopathy at all. These are the diabetics in your, if you have a practice, in your practice, you don't see any retinopathy. The question is, when will they develop it? Well, you can look up a book and say, well, on the average, it's 10 years or whatever. That's fine, and that's what you might tell a patient. But you could tell them a lot more if you had access to these kind of measures. So there's the answer to that first question. And then the very last question is, can those neural measures actually predict sight-threatening edema? Now we start to get attention from the ophthalmologist. Oh, you're actually trying to predict something that's useful? Yes. And the answer to that one has only just been published last month. Yes, it can. And without dragging you through how many subjects and patients and so forth, this was a tough study because identifying the population you want to study, you do things like say, well, they had to have diabetes at least this long. And there's a bunch of those that are outlined in the paper. But you still come up with pretty good sensitivity, very good, and specificity for patients in terms of predicting, not just predicting edema, but predicting where it's going to be. And I think I'm not going to drag you through that. I've said it all. It's delayed. It is a dysfunction and it's local. And you can use it to predict the onset. I'm not sure why. The application I've already mentioned, it could be applied if you're developing approaches to manage diabetics before they get retinopathy. It could be used by drug companies in a relatively short period of study time. Visual acuity, they give up. So they go to the FDA. The FDA says you need 2 lines of and that's the end of it. They will never study it. But if they had something that changed in a year or 2, maybe 3, then they'd be tempted, we think. And they sniff around. The edema part is roughly it's a tougher one, but you could do the study, you could identify the population as we had to that are likely to get sight-threatening edema, they're higher probability, and study them. And obviously, if you are successful, or the people who do this research, they would be able to do it at a greatly reduced cost. They'd be able to reduce the size of the sample they needed. They'd certainly be able to reduce the duration of the trial. And so I want to thank, at least with a slide, and I don't have them all here, but I've got as many as I could dig out, of the people who were involved in all of this over the journey that was from 1999 through the current years. And I will tell you that I'm retired, not totally mentally, but I'm retired from actively contributing something on a daily basis in this research. And there are 2 senior researchers on your right, Marilyn Schneck and Mark Bierce. Mark Bierce actually was a find because he actually helped invent the whole measurement in San Francisco, he and Eric Sutter. And they're in the lab, and hopefully they'll continue. One of them's just got an NIH grant, and the other one's is on a juvenile diabetes foundation grant. The others are transients. They are people who come in, get their PhD, and then take off. They're so thoughtless. They're the most recent ones on the side there. Wendy Harrison, Jason Ng, and Kevin, who's gone on to do a master's degree in nursing. He was so turned on to this whole diabetes thing that he said he wanted to go down a health careers path. And I said, why not optometry? He said, because nursing is more interesting. So there you go. thank you all for your attention, and thank you, Mel, for inviting me.
Don't go away, Tony. First of all, thanks again for coming, and thank you for your remarkable insights on diabetes. He reminds us again of something that is highly prevalent in our country and can only, at least prediction-wise, get worse. So it is highly relevant for us. Also giving us insights in the fact that we can, in fact, detect diabetic changes earlier than we had thought before. And Mike will have to get together and talk about getting one of those instruments for the clinic, right?
Just talking to Greg about that.
Okay, very good, very good. So if there are questions, this would be the time to ask them, please. Don.
So the cells that are giving the delayed implicit time aren't really where the blood vessels are. What's so special about their sensitivity? Are the blood vessels, what signals being sent out? What's messing up their responses?
The short answer is I don't know.
All right.
But there's certainly a lot of speculation in the lab, and it ranges. It's this whole vascular neural argument. You know, this is what I call beer talk. It's like which is first, the vascular change or the neural change? Is it just vascular and we're not seeing it, and so on? Clearly there are changes neurally, and there are also clearly changes vascular, and I suspect one day we'll know how to measure some of those vascular changes that can be said to be earlier than the neural changes. But it's not like there's the blood vessels aren't influencing the blood component, the chemistry, the chemicals are not impacting in that arena. And I think we'll find that there's more beyond just that area that I identified, that you'll get some effect at the receptors, you get effects elsewhere. And that those experiments were done on monkeys with Laura Frischman and Don Hood, where they, splashed chemicals on the retina and cut out this, and then splashed it on and cut out something else and said, it's here and it's here. They're not subtle experiments. They're, as you can tell by my saying they're splashed, but they're excellent first steps, in the sequence. And people like Mark Beer spent a lot of time thinking about that. He's a little bit more interested in the idea that, let's look at some other things, like alter the sequence of the flashes so we can say we're tapping adaptation mechanisms, whatever they are, and where are those mechanisms likely to be, and so on. So that's the long answer, but the short answer is I don't know. Was there someone over here? No? Yes, Bill?
So, Tony, years ago you showed that visual functional changes could track them with blood sugar levels, and that's probably one of the things that makes it hard to follow a swab. Does blood sugar level affect these, or is this more tightly?
It does affect them in the adolescence. I showed just one slide of that. It's a very recent slide. In fact, Mark gave it to me before I left and said you might want to show that. We haven't tracked. The stuff we did a long time ago was instantaneous, like blood glucose levels.
You showed it go up on the blood.
Yeah. But if you're being generous, we showed it in the sense that, if you look at a dartboard, you can see some holes closer to the centre and some not. I mean, it was noisy data, to say the least. You couldn't go to the bank with it. But the hemoglobin A1Cs, we were not measuring in those early days. I mean, it wasn't, we didn't have a physician in the lab, and it was complicated to go into that until now we can all measure hemoglobin A1Cs. You can measure them on yourself. But that's a relatively recent time. To me, relatively recent, it's within a decade. But it will be tied up. But people like Mark Beers, whom you know well personally, he's looking at a lot of the other blood chemistry elements that from his reading make some sense to study as a next step, to try to see what systemic measurements that are out there that are medically not only feasible but routinely done might be related to some of these measures. So there's a lot of work to be done. I mean, I'm excited about us being at this stage and being able to get some attention to the edema piece. But I think there's a huge amount of research that's still out there. There's a lot of PhD theses to go. And I won't be doing them, but mentoring them, I suspect. But we have one ophthalmologist in the lab right now, and she finishes hopefully next June or July. And she's doing a continuation of some of this. Anything else? No.
Don, has the software caught up on these commercial packages with your prediction models?
Keep going.
Would the commercial packages include your predictive software?
No.
Not yet?
No. They're easy to answer. With the short answers, I'm real good on those. I don't know. No. But yeah, I think it's. I mean, just getting someone to want to bother to follow. These are longitudinal models, so it's like, it's not like you walk into a practitioner's office and you've got the thing there, and you can apply it with the kind of and get a rig like this, and then convince somebody that they should apply it. Yeah, it needs to consolidate, it needs to settle down, the dust needs to settle. But there's no reason why it couldn't be. And there's no reason why a pharmaceutical company who thought they had a product couldn't engage somebody here or anywhere to look, say, okay, we've got this harmless drug that it's already approved, and we want you to track people for 1 year or 2 years, and then see if we've got any hope for it. That wouldn't take, maybe 40, 50 people. You'd have to do the calculations, but that's to me obvious. But it's not. Right now, everybody has their mindset on the advanced stages. That's where the money is. That's where the drama is. That's where ophthalmology's thinking is. I mean, but the acuity didn't change. And not just from ophthalmologists, but we get that a lot at meetings. Saying, well, no, it didn't. But, it's not normal, is it? Well, it's not abnormal if there's no retinopathy or it's not edema. And the FDA doesn't help, right? They don't have this as an outcome. So, there's a lot. I mean, I don't mind it. I've been in politics and, I'm in academia after all. And, and all of those things and kind of enjoy part of it. But it's a fairly hefty battle. I think it's going to have to be the companies that fight the battle until they're willing to throw some money at some people, like people in this room and elsewhere, to do a 2-year study or something like that to say, maybe your company could pay attention. Maybe you could get edge in. But no, they're interested in the stuff that restores removes blindness. And that's where they should start. I'm just trying to pitch, how about preventatives? Thanks, Mel.
Any other questions? Hearing none, we ended on a positive note. We're all about prevention, public health, et cetera, et cetera. At this time, we're going to have the presentation of the award by Dr.
I'll leave this in.
Myers. And if you will join me one last time in thanking our presenter for his fine presentation and for taking us on this journey.
Thanks very much, Mel. Thank you. Thank you. Have a good
As a reminder, we'll have a reception immediately following the presentation.
So, Tony, congratulations. Thank you for being
you.
here and adding your prestige to the lecture series. An awesome job, and I appreciate the opportunity this afternoon to
Yeah, that was fun.
We had a good time with that. And so we'll present the award, and congratulations.
Well, thank you very much. Thank you both. And thank you for honoring me with this. It's very beautiful.
So,
I'll have to carry it home in a wine styrofoam case.
we have the box. We have the box for you. So,
yeah. Thank you, Joyce.
Congratulations. So,
okay. Thank you both.
Come around the other way.